Well, after a busy week at the European Society of Cardiology meeting, we have a good roundup of top studies this week. At the number 3 spot, I'm going to put actually 4 guideline updates from the European Society of Cardiology. These span several important areas, including atrial fibrillation, where one of the big updates was a shift in the antithrombotic therapy for CHADS score 1 patients, so the lower risk patients. The European guideline now says that warfarin is preferred over aspirin in that low-risk population, whereas previous guidelines had said it was an equal choice between that and aspirin. Also, dronedarone was added as a treatment for atrial fibrillation. Then in the revascularization guidelines, they added ticagrelor, which is not yet approved by regulatory authorities, but under consideration. But that becomes another choice and one with a clinical advantage over standard dose clopidogrel for patients with ACS and especially undergoing PCI. There are also guidelines for grown-up congenital heart disease, or GOOCH, as it's known in the European guideline. And finally, one on cardiac resynchronization and device therapy. At the number 2 spot, we have a meta-analysis published as an expedited publication in JACC, where Tony Bavry and colleagues reviewed all of the pre-procedure statin studies, looking both pre-PCI, but also pre-CABG and prior to non-cardiac surgery. Together, they found 21 published studies and found a very large reduction in post-procedural MI, that is a 43% reduction, highly significant, by giving statins prior to the procedure. And so while we all think about beta blockade and now have to balance the timing of that, that there's another class of drugs really that we should think about in the preoperative evaluation of patients. And at the number 1 spot is the long-awaited publication of the current OASIS 7 trial. This was actually co-published, the main trial in the New England Journal and the PCI subset published in Lancet. This study looked at double-dose clopidogrel, a 600 milligram load and 150 milligrams a day for 1 week, followed by the regular 75 milligrams a day, as compared with standard dosing of 300 milligram load and 75 a day. Overall, the trial found no advantage of the double-dose clopidogrel, but in the PCI subset did find an advantage with about a 17% lower risk of cardiovascular death, MI, or stroke, and a lower risk of stent thrombosis. And so many caveats debated here, but many physicians have taken this to be a reason to use higher dose clopidogrel if that's the drug of choice for PCI patients. But there are other alternatives, as noted in the European guidelines, ticagrelor and also prasugrel. And so in the editorial, different scenarios are played out for which patients to get which drug. And we'll have to await the guideline update to see where that sorts out in the ACC-AHA guidelines. The study also looked at dosing of aspirin, regular 325 milligram versus 75 milligrams a day, and found overall no difference in the risk of cardiovascular events or of bleeding, for that matter, over a 30-day period. There was a lower risk of GI bleeding with the low-dose aspirin. And so these data also will need to get incorporated into the guidelines in terms of optimal aspirin dosing. So a big week, and that's what we have for the Cardiosource News Roundup. I'm Chris Cannon.